objectives here, I just want to go over with you guys the background for PAE, why we do it, how it came about, and then discuss some of the evidence behind it, and the 2019 AUA guidelines, which haven't been updated yet, but those are the most recent AUA guidelines with respect to management of BPH, and talk a little bit about risks of the procedure and complications, etc. So this, I made this talk originally for a grant rounds for urology here, to kind of introduce the urology department here to PAE, which was a little bit like going into the lion's den with a very delicious piece of meat, because they would just come after me. But everything, you know, I think we all approached it in a very scientific way, and we're all doing it kind of as a collaborative initiative with the urology department. So that's been, I was pleasantly surprised at how welcoming they were to this procedure, because it does kind of, for some patients, it does replace TURP. So that's the big objection that urologists have to it. So the first reports of PAE for BPH was done in 2000 when a guy called Demerit, who's, I think is up in the Northeast. He was a private practice IR, and he embolized a 76-year-old guy for a 300 cc gland who had refractory hematuria. And he wrote up the report because he noticed that the guy's symptoms improved quite a bit and his hematuria resolved. About a decade went by, and Carnevale and Pisco picked up that case report, and then they started doing studies of their own. And the first kind of series came out in 2010, 2011, and then after 2012, everybody started doing it. Everybody started publishing about it, and it's been growing since then. So the initial visit for PAE should be done in conjunction with urology when you are offering this procedure. We should have strict inclusion-exclusion criteria, and part of the reason for doing this with urology is that you're going to need their help for patients that need invasive urodynamic studies if you suspect intrinsic bladder dysfunction, because you're unlikely to help those patients. And then some operators do this, some don't, but I like to get pre-procedural imaging to review the anatomy, which we'll go over a little bit, and see if there are anatomical variants, because the pelvis, as you guys recall from gross anatomy, it's extremely variable. And I'm sure at some point in your mind when you guys were doing your dissections, you're looking at a pelvis and you're like, wait, the book says that the obturator artery comes off the anterior division, but in this guy, it's coming off somewhere else, and I don't know where the hell it's coming from. And you know, a lot of patients are not going to match what the book does, what the book says, which is I always thought was interesting. And also doing cross-sectional imaging beforehand gives you a good idea what the volume of the prostate is. It's a lot more accurate than transrectal ultrasound or digital rectal exam. So what patients do we treat? So the patient has to have lower urinary tract symptoms due to BPH and no other cause. So they can't have urethral stricture, they can't have cancer, they can't have lower urinary tract symptoms from anything else other than an enlarged prostate. Otherwise, there's really not much of a point in offering this procedure. Okay, the Qmax is a value that you get when you do a non-invasive uroflowmetry study. You basically get them to pee in this apparatus, and it measures how fast and how much flow they got per second. And it will give you a value called a Qmax, and that's the maximum peak flow per second during that voiding trial. And if it's less than 12, that's considered abnormal. Okay, that's consistent with an obstructed bladder outlet. There's a couple different validated questionnaires that are used for a subjective assessment of the patient's symptoms, and the IPSS is one of them. So the IPSS is the International Prostate Symptom Score, and any value greater than 8 for that is considered moderate to severe LUTS, and you're likely to help with those patients. Quality of life also is taken into account. A lot of patients don't want to take medications for BPH. So alpha blockers, for example, they cause dizziness, and then drugs like finasteride can cause gynecomastia. And a lot of patients can't tolerate it or don't want to take those drugs. And the patient has to accept that there are inherent risks to doing the procedure, primarily risks related to non-target embolization, like bladder injury, rectal injury, and then, God forbid, penile injury, which I've seen case reports of. But the risks we'll see later on, they're actually pretty acceptable. The risk profile of the procedure is pretty acceptable to a vast majority of patients. And the prostate volume ideally should be greater than 40 grams. I think less than 40 grams, you're not as likely to help. So a couple contraindications. So if a patient has the Truser failure, so intrinsic bladder problems, like Parkinson's disease or neurogenic bladder, so patients that have prior spinal cord trauma, and they have a bladder just doesn't want to contract, you're probably not going to help them very much. Active UTI is an absolute no-no, because you're going to be cutting off blood supply to the prostate, and if they have an active UTI, the bacteria may set up shop in the prostate and create abscesses or just this chronic raging cystitis that may become a serious problem. And then a couple of the other obvious contraindications. Of course, if you can't get into the vessel to treat it, you're not going to be successful. So if they have severe atherosclerosis, you may think twice about doing an angiogram in that patient. So why do we do PAE? It's the only procedure that's, besides high-focused ultrasound, it's the only procedure that offers a non-transurethral approach that's minimally invasive. So we don't have to instrument the penile urethra to do this procedure. We obviously go through the femoral or radial artery and navigate into the internal iliac arteries. The side effects and adverse events are completely different than TURP. The TURP's side effects are things like retrograde ejaculation, rarely, but not insignificantly, is urethral strictures and scarring, bleeding. All of those are risks of TURP that are not necessarily present with PAE. So you get very little incidence of retrograde ejaculation with PAE. You don't really see urethral strictures. You don't need to have a catheter in place after the procedure. You can go home the same day, that kind of thing. So it's pretty attractive to most guys that don't want to have an instrument shoved in their penile urethra. So the patients that have really large median lobes are unlikely to benefit from some of the other alternatives like UroLift, and PAE may help in those patients as well. So this is a patient that has a huge median lobe. You see this thing shaped like a snowman, median lobes protruding into the bladder by several centimeters. That's a patient that is probably not going to benefit too much from a UroLift. The alternatives here are to go and TURP this median lobe out to kind of cut out that median lobe, or a PAE to just shut off blood flow to the median lobe. So why does it work? So we still don't know 100% why it works, but we think that when we cause ischemia in the gland, it's going to shrink. And we know that the extent of the ischemia after the procedure is going to correlate positively with clinical outcomes. So about 50% of patients will have necrosis that you can identify on MRI. Other reasons why we think it works is that we're going to reduce exposure of the tissue to hormones, which cause further growth of the gland. And we also are going to be destroying these alpha adrenergic receptors that are in the smooth muscle of the prostate, causing it to permanently become relaxed. So the reason why the alpha blockers work is because it relaxes the smooth muscle tone in the prostate and allows the urine to flow through the prostatic urethra more easily. And this may be a similar thing that happens when you get a PAE, just as a long-term thing that's not really that the tissue doesn't recover from. Let's look a little bit of the anatomy. So why do interventional radiologists, why are they the only people that offer this? Well, because the anatomy is super complicated. And we are the only specialty that has significant microcatheter skills that will allow us to get into these blood vessels. Okay, so you look at an angiogram like this, you're like, what's what, you know? Unless you've seen a few of these before, you're probably going to get really confused. So one or two of these arteries, I say one or two because some people may have more than one prostatic artery in the side, but one or two of these arteries is prostatic artery, and then it's your job to find it. So where the hell is it? So you have to know what the anatomical variants are going to be, and the origins are from almost anywhere in the internal iliac artery, or it can also even come off the external iliac artery in some cases. So the most common origin is going to be the internal pudendal, with the superior vesical artery being a close second, and just having other gluteal pudendal trunk origins as well being pretty common. Not infrequently it comes off the obturator, and the obturator itself can come from the superior gluteal, it can come from the anterior division, and there's a variant of the obturator artery that comes off the inferior epigastric artery. It's called an aberrant obturator, also known as a corona mortis, and that can give rise to a prostatic artery too. So the variation, anatomical variation for these patients is pretty tremendous, and I think it's part of what makes the procedure really interesting. So the CTA kind of helps you identify the prostatic artery, in this case a MIP showing the anterolateral branch from the obturator artery, and then there was a posterolateral branch from the inferior gluteal artery. So this guy had two prostates on that side, two prostatic arteries on that side. And there they are. So it's helpful to know that beforehand so you can kind of approach the case without wasting too much time looking around. One of the things that we do during the procedure too is cone beam CT. I don't know if you guys seen this on rotation yet, but we can spin the image detector and the source, the fluoroscope, around the patient and then use that data to reconstruct a CAT scan type of image. And that's exactly what we did here. This is a injection of contrast when we have the left prostatic artery selected. And you can see half the prostate's enhancing really nicely there. There's a bunch of little dots anterior to the prostate. That's the periprostatic venous plexus that's enhancing. That's normal. And the cone beam CT is really helpful to show us whether or not we're going to be enhancing stuff we don't want to embolize, like the rectal mucosa. So the picture here is showing the rectal mucosa around just posterior to the prostate, and the arrows are showing that there's no enhancement of that rectal mucosa. So it's a safe position for us to embolize with the catheter. And we can go ahead and treat in that position. So what do we embolize with? There's a bunch of stuff that we can shoot into the arteries. So they've published a bunch of different studies using PVA particles, embospheres, etc. The most commonly used type of embolic nowadays is their spheres. There's a bunch of brands of spheres, you know, you name it. Some of them are non-calibrated, some of them are calibrated. There isn't really a consensus on the size that's ideal for PAE, but it's been established that spheres are superior to PVA. PVA is this embolic that's been around for 40 years that has is made out of plastic and has little plastic shards. It looks like the stuff that you see inside a snow globe, and it tends to clump. And when the embolic clumps, it's going to be less predictable, because if you get a clump of PVA traveling down the vessel, it's going to lodge itself much earlier than it would if you than you intended potentially. So if you want to embolize like a 100 micron vessel, and you say, okay, I want 100 PVA, and then the particles clump, and you still only get 300 micron particles, you're going to end up embolizing a lot more proximal. And the reason why that's important is because the more proximal your embolization is, the more collateral flow you're going to get to the target. That's a really important principle in IR. Okay, so and you can that can be good and that can be bad. So if you're trying to cut off blood supply to an organ because it's bleeding, and your goal is really just to slow down the blood flow so that the bleeding, you allow the patient to stop the bleeding on their own, you want to embolize proximally. Now, if you have a tumor in the liver, for example, and you want to kill it, you don't want to embolize proximally, because that tumor is going to recruit vessels from around the from all around the liver to feed itself. So what you want to do is you want to do a really distal embolization, and that will choke off the blood supply within the tumor itself if you do it distally, and you won't allow it to recruit collateral. So for the prostate, the goal is to infarct the gland, so you want to do a distal embolization. So that's a really important principle of embolization that you guys will hear about again. So current AUA guidelines. So why are we talking about this? Well, it's because this was a review of the literature that they actually paid attention to what interventional radiologists are doing, and they decided to make an opinion about it. And they are saying that PAE is not recommended for treatment of lower urinary tract symptoms outside the context of a clinical trial. So basically what they're saying is that we reviewed the data, and our expert panel saying that this really shouldn't be offered outside a clinical trial. This is still kind of an investigational procedure. So why are they saying that? Because we have, you know, over 10 years of experience with this procedure, and we have dozens of articles published about it. So why are they saying this? Well, it's because they, and first of all, I wanted to define what an expert opinion was. That's a statement achieved by consensus of a panel based on members' clinical training, experience, knowledge, etc., and a judgment for which there is no evidence. Okay, so it's a kind of a strange opinion, strange recommendation in the AUA guidelines. And then how they arrived at that opinion is even more strange, because they reviewed only a very, very small slice of the available literature that I'll show you guys. So I criticized this opinion in front of the urologists here, because we are really, the IRs are really the only ones that have the training to offer PAE. You know, the endovascular techniques required to do PAE are acquired only by a long time training in IR. And even within IR, even if you are a board certified interventional radiologist, you probably need a little bit of extra training to do PAE itself, because of the anatomy and because of the microcatheter skills related to it. So most urologists are not familiar with the experience of PAE. So urologists that have seen patients have good results from PAE tend to view it much more favorably. And knowledge about the data for this opinion only came from 3 studies, which is I thought was really weird. So which studies did they choose? They chose 3 randomized controlled trials, and they chose those because they were randomized controlled trials. Okay, so it's like we're only going to look at randomized controlled trials because everything else doesn't count because it wasn't a randomized controlled trial. Even though some of the series had hundreds of patients, and at this point there were meta-analyses that have been published, and meta-analyses are considered high-level evidence. Okay, and they also didn't count for multi-institutional prospective trials, which, although they weren't randomized, they were still high-level evidence by virtue of being highly powered and also having clean prospective data collection. So this is a list of all the available PAE studies up until 2019 when they published the guidelines. And there's 44 studies, 3,000 patients, 19 centers. This is not including the UK ROPE registry, which was one of the more recent multi-institutional studies that was done on PAE. Once you account for overlap and account for authors that are double dipping on their work. So one of the things that happens is authors will try to publish their data in different journals at the same time, which is unethical, but sometimes they still get away with that. A lot of times they will publish a series of, say, 12 patients between this period and this period, and then they'll come back and have, oh, now we have 48 patients between this period and this period, but that data includes the 12 patients they previously reported. So to write a meta-analysis on PAE, you have to account for all of that. And once you get, once you account for all the overlap, you get 24 studies, 2,400 patients, and 12 prospective studies, and 6 randomized controlled trials. So the slice that the AUA got in the literature was only about 9% of what was available at the time. Okay, it was a kind of a weird group of articles that they selected to make the to reference in the guidelines. So we'll talk a little bit about the UK ROPE study. This was a pretty glaring omission in the guideline. It was available to them at the time. This was published in 2018. It had 17 hospitals and it had 216 PAE patients and 90 TURP patients. The results were pretty in line with what you see in the literature. So median improvement was about 10 points in IPSS at 12 months. For the TURP population, it was 15 points. The 70% of patients were done, had PAE done as same day and went home. 80% of TURP patients spent at least 1 night in the hospital. So the most patients that had a PAE had a bigger prostate. So the average volume in the PAE group was bigger to begin with. So we know that the limit for TURP is about 100 grams. So it's pretty natural that you would include patients that have bigger prostates in the PAE group. And return to activity was faster in the PAE group than in the TURP group. It was 5 days versus 2 weeks. So clinical failure rates, it was a little bit higher in PAE. And then after 12 months, that clinical failure rate really jumped for PAE to 15%. This is where I get the, when I'm talking to these patients, this is where I get my spiel about telling them that roughly 1 in 5 men will need something else done at some point. Okay, because we get about a 20% requiring something else or having clinical failure at some point after the PAE. That number is only 5% for TURP. Here's some more of the stats. So the overall improvement in IPSS score. The IPSS score goes up to 35, so 10-point improvement is pretty good. Certainly enough to be statistically significant. That improvement was a little bit better in the TERP population. Quality of life improvement was similar. There was no difference in the erectile function between the two groups. Both groups had a improvement in the urine flow. The TERP was a little bit better. And post-void residual was also a little bit improved in the TERP. So I don't know why they didn't include this study, because it's a large study showing that TERP has better results, you know, but that's not the whole story. The better results that you get from TERP are at the expense of having to have a much more invasive procedure and different side effects like retrograde ejaculation. So you get more hematuria, okay, when you do a TERP. You get, there's a higher incidence of incontinence. You get a much higher incidence of retrograde ejaculation. And if you really dig into this data, you'll find that they actually included patients that had prior retrograde ejaculation from alpha blockers before getting the PAE. So that was kind of a strange inclusion. I don't know why they included those patients, but one of the side effects of alpha blockers is retrograde ejaculation. So those patients were included a priori in the analysis. But I suspect that if you don't include those patients, this number will be much, much lower, because it's really rare to get retrograde ejaculation when you do a PAE. So hematuria, hematospermia, most common adverse events. I think they probably didn't include dysuria as a adverse event. I'm not sure why, but that's a very common side effect from PAE. Also, probably every guy that gets one has it. So the UK rope study showed that the PAE works. Maybe it doesn't work as well as a TERP does, but the side effect profile is completely different. So why that wasn't included, it's curious to me. So why did they choose the randomized controlled trials? Because a randomized controlled trial is considered to be the one of the highest levels of quality for evidence. But but that depends on who you ask. You know, if you look at the evidence-based medicine pyramid versus the U.S. Preventive Services Task Force criteria for clinical evidence, the EBM pyramid considers systematic reviews and meta-analysis probably the highest level of quality evidence that you can get. Okay, because you're not just looking at one trial; you're looking at multiple. You're looking at a set of pooled data that has been analyzed. Okay, so the best way to do that, the best way to do a meta-analysis is to do a random effects approach. It allows the analysis of pooled data from heterogeneous data sets, which means that you can pull data from studies that are not exactly done in the same way, and you assign weights to them based on how much those results vary. Okay, so it's going to reduce the impact of a 600 patient series when you have also in that data set like a 50 patient series. So those weights, they are accounted for. So we'll look at the weight of this evidence once we look at the meta-analysis by Malling. So this was the most recent meta-analysis done in 2019. It met all the criteria that I talked about earlier, like overlapping data, etc. So one of the things that they did was they emailed the authors asking for patient level data, and why that's important is because it allows you to pull the data much more accurately than if you're just extracting the data from the paper itself. So patient level data will allow you to get much more accurate standard deviations and variance in the data that you're looking at. This was a 1,200 patient meta-analysis. Here are the results from it. So it showed a improvement of 14.5 in the IPSS score. There was a slight improvement in the erectile function overall. PSA fell a little bit. Prostate volume decreased by about 15 cc's. Post-void residual improved by about 50 cc's. Qmax was improved by 4. Quality of life on average at 12 months was improved by 2. All of those were significant. There's another meta-analysis by Jing. This included the UK rope study. It was a meta-analysis of randomized controlled trials and the UK rope, which wasn't randomized, but they included it in there as well. So the IPSS improvement was about 12.8 for the TERP. Sorry. Yeah, 12.8 for PAE and 10 for PAE compared to the 6.1 and 13.1 for the TERP. And rate of complications. Tended to favor the PAE group. Problem is that they included clinical failures and adverse event in one of these studies, which kind of artificially raised the PAE group as well. The adverse events that you find from PAE, there's a whole list of them. The most common things are going to be dysuria. So basically, I tell all the patients that are getting PAE that they're going to get dysuria. Okay, they're going to get urinary frequencies. The first couple nights after the procedure are pretty miserable. They're getting up multiple times a night to have to go urinate. The really dangerous things like severe UTIs, bladder wall ischemia, pain, or rectal ischemia, those are pretty rare. There are reports of penile injury with like penile ulcers at the glands that heal spontaneously and they're really scary, but they kind of go away on their own. Those are pretty unusual. Risk of having to have, you know, like a surgical repair of a rectal or bladder ulcer after PAE is less than 1% based on the literature. So I think that once you take into account the high level evidence coming from meta-analysis, the evidence in support of PAE is pretty strong. I think we're at a point now where it's being offered out in the community quite a bit. The insurance companies are starting to reimburse for it now, which the AUA guidelines really didn't help much with it because they said that you shouldn't do it outside clinical trials. But I think that once the insurance companies are provided with information about how much money you save doing a PAE versus a TERP, they're happy to cover it. So, and that's what's been going on for the last couple of years. So the complication rates are really, or the complication types are really what attracts patients to getting a PAE, because it's a completely different animal with respect to what you get after the procedure, and the recovery is a lot smoother in many ways. It's unfortunate that they put an expert opinion type of recommendation in their guidelines, because I think that the systematic reviews, randomized controlled trials, and cohort studies that are available for PAE are a much better level of evidence than what they used with the 3 randomized control trials that they have. All right, do you guys have any questions? That kind of sums it up.
Yeah, I have a question, Dr. Uflacker.
Go ahead.
So it seems like, a common theme that you were presenting on was just evidence and how certain trials like the Rogue trial, or even just as small as including patients who experienced retrograde ejaculation but were previously on alpha blockers, something like that. You kind of pointed out quite a bit of examples. How, in your opinion, do you feel like IR in general has to deal with, kind of a lack of complete evidence in its presentation, or at least an expert opinion? I feel like a lot of IR is kind of pushing the boundaries of other fields of medicine, at least as far as procedures go and routine care. So do you often find that this is an issue, especially when coming up with new and novel procedures?
Yeah, that's very common. So we deal with that all the time. And there are multiple examples of that. So we'll talk about uterine artery embolization in the next lecture, but it was a very similar thing that happened. But that was back in the late 90s, early 2000s. We started doing uterine artery embo. Insurance wouldn't cover it. The gynecologists didn't want to talk about it. But women were looking for it because a lot of those women didn't want to get a hysterectomy. And that's why they were looking for UAE. And then what we have to do as a specialty is just churn out high-level data to show that yes, this thing does work. And you got to be careful when you're doing that. You got to be careful not to bias yourself too much in favor of what you're doing. You have to be as impartial as you possibly can when you're evaluating your own procedure. I think there are examples of things that haven't taken off, like I don't know if you guys heard about bariatric embolization, but around the same time that PAE started becoming hot, there was groups of IRs that were looking into doing left gastric artery embolization, and it's really interesting approach to management of weight loss. What you're doing in bariatric embo is you're knocking out these cells in the fundus of the stomach that secrete ghrelin, and you can actually embolize the fundus of the stomach without causing ulcers if you use the right particle size. So remember that discussion I had about the level of embolization that you're doing. So if you go too small, you may cause too much tissue injury. If you don't go small, if you go too big, you may not cause enough of the effect that you're wanting to cause. So if you get to the right particle size in the fundus of the stomach, you can knock out these ghrelin secreting cells and spare the mucosa, and what that does, it just inhibits appetite. The bariatric surgeons, absolutely hate that procedure, but the evidence behind it hasn't really been that great. You get like maybe a 15% loss in weight for some patients. It doesn't really work for everybody. So the adoption of bariatric embolization has been super slow. If they had come out with really good evidence out of the gate, showing that bariatric embo had, as good a result as bariatric surgery, then I'm sure we'd be doing a lot more of that today. But that just didn't pan out. The evidence for UAE and PAE are just much better in those terms. And the same thing happened for whenever we come up with a new way to treat cancer. Like Y90 was not reimbursed by insurance for a long time until high-level evidence came out in support of it. So yeah, we face this all the time. I think a lot of different specialties do, but us in particular, because we're always trying to think outside the box, we deal with this kind of problem a lot. Yeah. Does that answer your question?
Yeah. No, thanks for giving the bariatric example. It kind of shows like how certain, even if effective or just the trials and getting a process started for a new procedure can be difficult, especially if it's, the evidence, like you said, or is not being presented completely. So
yeah, and we're doing the same thing right now actually with geniculate artery embo. So you'll think that IRs just want to embolize everything, but the rationale for doing geniculate artery embolization is that when you decrease the blood supply to the inflamed synovium and the knee, so people who have knee osteoarthritis, you get a lot of blood flow in the synovium, and that blood flow comes with comes from neovascularization, right? So you get new blood vessels forming, and when you get new blood vessels forming, you also get new nerve fibers forming that, and a lot of those nerve fibers are nociceptive. So the inflamed synovium is in no small part responsible for a lot of pain and osteoarthritis. And a guy in Japan called Okuno, back in 2014, 2015, started injecting these antibiotic particles of imipenem celastin that are available in Japan. We don't really have it here in the United States, but it was a temporary embolic. And he noticed that people felt improvement in their symptoms of osteoarthritis, and it was like a durable improvement. It was like for more than 12 months, out to like 2 years. I think he was able to start doing that because this guy's father was an orthopedic surgeon, so they probably had a lot of discussions about, what do we do for patients that are not candidates for total knee replacement but are, addicted to narcotics, or had a bunch of joint injections that didn't do anything, and they said, well, the synovium is hypervascular, maybe we can embolize it. And they tried it out, and suddenly now everybody's looking at geniculate artery embolization, including me. So that's, I think, kind of be the next frontier. So that's part of the reason why I like IR, or a lot of people are attracted to IR, because we're always kind of pushing the boundaries of what's doable. So yeah, any other questions?
Yeah, Dr. Uflacker, do you think, so kind of with these professional societies and like what their opinions are about things, do you find that IR has to like prove themselves to the insurance companies, and then those professional society opinions change and maybe they kind of revamp them, or do you have to prove yourself to those professional societies, and then based on the recommendation that they make to insurance, then you start to get reimbursement for it?
I think it's a process that kind of happens in parallel. So it's not like we want to conquer the professional society first, and then tackle the insurance companies. I think it all kind of happens at the same time, and the way it happens, it's a lot of it is through just interpersonal relationships. So the people that are doing PAE, they'll know a few urologists, and it becomes like a phenomenon where, okay, this urologist and that urologist, they trust me. I've done a few PAEs. Patients are coming in asking for this. They're like, okay, well, I'll give it a try. Then they see, okay, it works. They're like, all right, well, I guess it's not as bad as we thought it was, And then for the insurance companies, what they want to know is it save money? Does it work? Does it save money? And does it make sense for us to cover it? If we make this part of our plan, covering this procedure, are people want to go with our plan? Are people going to ditch our plan and go with another insurance carrier because we're not covering this procedure? Those are questions that they think about. A really good example of this is pelvic vein embolization for gonadal vein insufficiency, also known as pelvic congestion syndrome. So the pelvic congestion got a huge bad, like a extremely bad reputation early on with gynecologists. I have maybe I should do a talk on gonadal vein embolization instead of UAE, because I think it's actually more interesting. The difference in how the gynecologists approach the problem versus how IRs were approaching the problem is that IRs understand that the veins, when they get distended, they can cause pain. So you get distension of the vein. They cause inflammation in surrounding tissue. You get all the cytokine release. You get substance P activation, et cetera, et cetera. So you get pain. Just ask anybody that ever had a hemorrhoid, okay, how painful a hemorrhoid is. And basically what pelvic congestion is, you have veins that are distended, kind of like a hemorrhoid, but they're around your uterus. So it can cause all sorts of problems, like pain during or after intercourse, pain throughout the day. So when you're standing, the blood flow is going to go towards the pelvis because the gonadal vein is going to be the ovarian veins incompetent, so the valves aren't working to keep the blood from flowing back down. So what do? We go in and we block the ovarian vein, and we sclerose the veins in the pelvis to keep the reflux from going. Problem is that pelvic pain is super complicated, so there's multiple factors associated with pelvic pain. Veins are just one of the many causes of pelvic pain, and coincidentally, a lot of women that have pelvic pain have this finding of dilated veins around the uterus. So the results are not quite as strong as they are for UAE, for example. So it's maybe about 50-50. The literature is actually showing that the results are 50 to 70% improvement in symptoms for women that get pelvic vein embolization. But I think in clinical practice, my batting average is probably about 50-50, and that's because it's a pretty multifactorial process. So why do we do it if it's only about 50-50? Well, it's because a lot of these women come to you and they're like, well, everybody thinks I'm crazy, and there's nothing that works for my pain, and you're the last hope that I have. You're like their Obi-Wan Kenobi, and they just come to you and they're asking. I mean, we're desperate. We want something done, and so you have to talk to them. You have to say, look, this is a complex issue. The veins are only one cause. We don't fully understand why some women have pelvic pain and some don't. Even women that have huge distended veins in the pelvis, a lot of them don't have pain. It's weird. We just don't understand why. So at a minimum, we're going to be taking the dilated veins off the table and finding out what's causing your pelvic pain. So but some women, you do the procedure, they come back, they're the happiest people. Some of them that come back and are like, yeah, that really didn't do anything. So we've yet to understand why. And insurance companies really don't like paying for that procedure, even though there's evidence showing that in a lot of cases it helps, and that's really the only thing that they have going for them is this procedure. But that's a topic, but for another day. But that's a pretty interesting one too.
Where do you see PAE kind of like fitting into like the I guess the stepwise treatment of BPH? Because I feel like what you're kind of saying is like there's less side effects to it. I mean, people who have BPH also tend to be older. They might not be great surgical candidates. Like, could you see it as being as like an initial step, and then if it fails, because it does seem to have higher failure rates than TURP, then you move to more invasive TURP? Like, where do you think you could see it happening?
I think it's completely. I think PAE is one of those things that's completely patient driven. So it's really if you're going to create an algorithm for it, it is going to be challenging because it really it doesn't fit neatly into any box in an algorithm, because you have to take into account patient preference. Like for treatment, there's treatment algorithms for everything, right? For cancer, You know, the patient has cancer. The patient doesn't come to me saying like, "Oh, I really want a Y90. I don't want you to do an ablation. I really want you to do a Y90." You know, they're going to go with whatever you recommend. You know, that 99% of them are. You know, you still have to have a risk-benefit discussion about everything. But with cancer treatment, there's a very algorithmic approach to it. With PAE, you can have it can be part of a treatment algorithm, but patient preference is going to be trumping most of the anything you put on an algorithm, because even if a guy is like, even if you say, oh well, prostates that have, you know, there are like 40 to 80 grams, you know, should undergo TURP first. A lot of guys are going to say, wait, I don't want a TURP. You know, I don't want to have retrograde ejaculation. I don't want to have a catheter for a few days. I don't want to be in the hospital. I don't want to go with general anesthesia, etc. So I think it's going to be very similar to how UAE is approached. It's going to become, I think, is eventually going to become part of the informed consent for management of LUTs when urologists discuss it with the patient, because it's an alternative, and you have to talk about alternatives, viable alternatives that are supported by evidence when you consent somebody. Okay, so it's not really ethical for a gynecologist to talk about management of fibroids and say only, oh, the only options you have are hysterectomy or a myomectomy. Okay, that's it. There's nothing else. You have to say that, well, UAE is also an alternative if you're interested in getting something non-surgical. Doesn't work as well as a hysterectomy, but it's a reasonable first try. Same thing with PAE. You know, it's the exact same thing.
I think this kind of leads into my other question, but especially a lot about these kind of almost, I mean, pretty much elective embolization procedures almost. It's like, how do you, and this might be a more difficult question for you being in the academic setting. So how do you think that IRs, both academic and private practice, like how do you think they could build a patient basis? Because I mean, obviously, like some of this, I feel like you need the buy-in of these other fields who want to refer patients to you, but also I feel like you're beholden to them. Yes, correct.
Yeah, you depend on them at the same time you're competing with them. So it all comes down to relationships that you have with people, you know, because the urologists are going to need you to put in the nephrostomy tubes and manage bleeding and do a number of different things, drains, whatever, and help them out when they have problems. And if you have a good working relationship with them, they'll, you know, you'll be able to build a practice, and patients are going to be asking for this. So that's another aspect of it. You know, they're going to be asking for it, and they're going to want to see a urologist that knows a guy that does PAE, right? So, and if you have that relationship built, then you know you'll be successful.
Final question. I won't hold you any longer after this one, but
no problem.
Kind of, I mean, I feel like whatever these older patients, I mean, the saying is that, you know, you never die from prostate cancer, but a lot of older men have prostate cancer. Like if you see prostate cancer, is that a hard contraindication? And then second question is that is there any like study into whether you can use PAE to actually treat prostate cancer?
People are starting to look into that. There's a couple studies that are very, very preliminary about it that show that there's maybe some effect, but the answer is we don't know. You know, and if a patient has prostate cancer, I'm inclined to say let's not do the PAE treatment for a couple of reasons. One is it's going to become really unreliable. PSA is going to become really unreliable as a marker of prostate cancer progression. Okay, so because your PSA is going to drop after you do a PAE, acutely it goes up and then it goes down. And if you have prostate cancer, you may have an artificially lowered PSA that may be not indicative of whatever process is going on in the prostate in the setting of cancer. And then second, when you image prostate cancer, it depends on enhancement curves on MRI. and you're also going to be messing with that when you do a PAE. So both those tools become kind of unreliable after you do a PAE. I say it's unreliable because we don't know enough about it. It could very well be that it's fine. It's just that we don't know.
Gotcha.
So I usually counsel those patients to get a TURP.
Okay.
If they have biopsy-proven prostate cancer, even if it's just a very early stage, say just get a TURP. Because yeah.
Oh, sorry, I didn't mean to interrupt you. I did have one more question, just to think about it.
Yeah, go ahead.
Are there kind of like any anatomical variant? I mean, obviously you use the CTA to best map like where the prostatic artery is, but when you go in there and you're actually doing the angiogram, like, and you shoot contrast and you see some enhancement of the rectum and things like that, have you ran into that situation where you're like, I'm here in here now, but there's an anatomic variant that is just going to preclude? Okay, yeah, okay.
Yeah, you run into that all the time, and you have to figure out how you're going to mitigate that non-target embolization. You have to kind of judge, is the degree of enhancement that I'm seeing here going to be enough to worry about where my catheter is? Do I need to reposition my catheter? Do I need to coil this branch that's going to the rectum to protect the rectum from the embolic? Do I just increase the size of my particles? Like I said, if you do a bigger particle embo, you're not going to infarct as much tissue. So do I increase the size of my particle? What do you do? Then those questions come up in every case.
Okay.
So yeah.
Cool.
Yeah, it's cool stuff.
Definitely cool. You got any more questions on it?
No.
Okay,
no,
cool.
That was awesome.
I appreciate it, Dr. Uflacker.
Yeah, no problem.